Now recording. All right.
All right, awesome. Well, again, thank you guys for coming out to our Amsa meeting this Wednesday. Josh, again, our president, unfortunately has class during this time, so he's still contributing behind the scenes. He's actually made these slides for us, and he always throws in a lovely meme. So for this week's meme, it's your cholesterol levels are excellent, but you still won't make it past February. And on that topic, pretty glad that the weather's finally clearing up and we're getting into the 40s and 50s. So that's definitely a plus side.
Okay, so first off, t-shirts have been finalized. We're gonna start sending out links and stuff soon enough to you guys, so you can start ordering those. Bonnie can talk about the pre-white coat, right?
Yes, so Amsa's officially done their first podcast. Essentially, our e-board gets together and we kind of talk about some topics currently relevant to you guys. We recorded our first episode, so that should be up soon on our social medias. You'll be able to find it on YouTube, IGTV, Facebook, and much more. So we hope you guys look forward.
All right, as well, the third bullet point there, no meeting next week. Of course, it is our spring break part 2. I think the official spring break, if we want to call it that. Take the time and enjoy it. We all, on behalf of Amsa, all hope you guys have a safe, restful, and enjoyable little break now before kind of we hit the home stretch on this semester. But then, since we have no meeting, just information about the week following next week, we will have on Tuesday, the 16th, a joint meeting with ACE, MWA, and LEC mentors for an admissions rep. Look forward to more information about that, and I'll be covering it on the last slide as well as our usual Wednesday meeting on the 17th with a very, very interesting transplant surgeon. For those of you who were with us last year, he actually also came in the spring and offered us a very interesting look at how he basically centrifuges entire pancreases and essentially injects them into people. So maybe we'll talk about the same thing, maybe not, but definitely look forward to that.
All right, and now I'm very excited and happy to introduce today's speaker, the Director of Education at Superior Air Ground Ambulance Service, Brian Melville. Feel free to take it away, Brian. And if you need to share any your screen or anything, just let us know.
No, that's okay. You'll have to deal with my ugly mug, whether it's bearded or not. Good evening, everybody. So I was asked to come speak on emergency medical services and its value in the healthcare setting. So what I'll do is I'll just give you like a brief history of emergency medical services, kind of talk about the structures of the different formats of types of EMS, what different areas we function in, and really just open it up to questions, and talk about its value. As far as now, you are all pre-med, is that correct? Are you all medical students currently?
Yeah, no, majority of us are undergrads, or all of us are actually undergrads at Loyola, and majority of us are pre-med or planning to be on that pre-med track.
Okay. Do I have any future trauma surgeons in the room? Don't know. Some people have their passion right away. Some some find it as they're making their way through medical school and doing different rotations. So really, as far as emergency medical services are concerned, we are more of the pre-hospital medical care. So before they come to you in the hospital, we're the ones that are scooping them off the street. We're the ones that are dealing with them at their moment of initial complaint. And it's got EMS has a very long history of even though it seems like a long history, we're very young as far as the field of medicine is concerned. I mean, EMS was really born in the 1960s. So there was a white paper that came out on crashes and trauma in 1966. And that white paper identified that 44% of trauma death was caused by crashes. And so what that white paper identified was a real need to have pre-hospital medical providers that can get to these patients as close to the time of injury as they can and get them to the hospital where they can have definitive care. And that model really, hasn't changed as far as that need. That's still what we do. While our scopes of practices have really expanded, in the very, very early days, ambulance services were run by funeral homes, which seems a little, there may be a conflict of interest there on survival of the patient, it seems, but they were the ones that had the vehicles that were capable of transporting the sick and injured lying down and getting them to a hospital. And then after this they identified that the Vietnam War occurred, and people were getting better treatment on the battlefield than they were getting treated in our own cities. And again, really identified that patients just needed more than transport to the hospital. What they needed was somebody that had some sort of training and skill to manage them and get them there. And that's what's evolved really over time, for pre-hospital providers. I mean, it used to be a really big deal to have somebody who was first aid trained, and then you were really high speed if you carried oxygen with you. Over time, enter the 70s, and a TV show called Emergency. Everybody here probably has not heard of that. Us old heads in the EMS game, we used to refer to that as watching training videos when we'd watch old episodes of Emergency. But bringing emergency medical services into pop culture really really brought it into the limelight and got people interested in EMS. And by the time that show came out, emergency providers were doing more than just carrying oxygen and first aid in the field. This saw the dawn of the birth of paramedics, which were trained in more advanced skills in airway management, more advanced skills as far as beginning IV therapy in the field and giving medications pre-hospitally, and then getting them to the hospital. Now, of course, science evolves. Some of the stuff that they did back then, we would look at that now and go, "Oh my God, you're killing the patient." But that's just kind of the nature of medicine, right? That's why we call it practicing. It's always evolving. So, what the model of emergency medical services look like is there's various levels of scope of practice. So you have emergency medical responders, or EMRs, which are very, very basically trained. As a matter of fact, I just spent last week, I spent 6 days training our very first EMR class at Superior. We're looking to work with the state of Illinois to use emergency medical responders as drivers, so that they could have a driver up front, an EMT in the back, and they're pretty much going to be taking care of like very non-acute patients. So patients that are bedbound, they are otherwise okay. They're not having any medical emergencies. We just need to get them out of the hospital and probably take them home or back to a skilled care nursing facility. EMS is in a variety of different sectors. We are, as far as Superior is concerned, we are a private ambulance service. So there's more than just the 911 fire department aspect to that. I'll speak on that in just a minute. So emergency medical responders are like your entry level. You are still taught the very, very basics of anatomy and physiology. You still go through the very, very basics of the the various problems that can happen in every body system. And then the training and the depth of training gets more and more intense as you move through. So when you move up to emergency medical technician, or EMT, this allows you a broader scope of practice. So now you're talking about being able to deliver medications, whether that is through nebulized medications such as breathing treatments, or administering intramuscular injections such as epinephrine for allergic reactions. And their scope is expanded to a point now. I mean, when I went through EMT, and I'm not going to tell you how long ago that was, but what I was teaching for EMR this past week is more than what my EMT program was when I originally was certified. So now emergency medical technicians, EMTs, are using CPAP in the field. If you're familiar with what CPAP is, continuous positive airway pressure, it's a device that's designed to keep the airways open. We use that for a variety of different conditions, heart failure, asthmatics, COPD patients. It's basically just taking air pressure and splinting your airways open from the inside to make it easier for the patient to breathe. Also popular for, hypernourished people like myself that have sleep apnea. That's not a real medical term. Don't jot that down. Don't use that on any exam. So as you move through EMT, then you become a paramedic. Now with the paramedic, your scope of medications that you can administer greatly expands. The types of procedures that you can run greatly expands. So the paramedic is trained, while EMTs are running around with automated defibrillators, paramedics are trained to identify and treat a variety of different cardiac rhythms. And that includes not just medicinally, but electrically, delivery of what we like to call Edison medicine to shock the heart into doing something normal. And, through cardioversion, defibrillation, we take over the impulse of the heart and we pace them. So we become an external pacemaker. And all of this is just to get them to the hospital where, future specialists like yourself are going to be taking over care of a very sick person. And we try and get them there in as best a shape as we can. After the paramedic level, it expands even more. We've got critical care. So they are dealing with different pieces of equipment, such as balloon pumps, which a balloon is inserted through the femoral artery and seats itself in the aorta. And a balloon inflates and deflates in timing with the heart to ease the workload. So there's a lot of stuff that goes on. ECMO, which is basically the heart and lung machine. We've got people transporting ECMO in between facilities. You have somebody that's waiting for a heart transplant and the heart's at a different hospital. They might put the patient on, or have the ECMO patient transported by ambulance to get them to where that heart's at. So there's a lot of stuff that happens on the ambulance outside of just somebody calling 911 and us walking through the door. So you've got transport EMS like Superior is. You have your 911 services, which are generally paramedic staffed. Not everywhere though. You go out in the more rural areas, and rural EMS has its own challenges because you're so far away from the closest hospitals. So they almost have to be better than what your urban paramedics are or can do, because they have to manage the patient for a much longer time. And a lot of times out there, their towns don't have money, so they're running on volunteers, people that go to paramedic school and then they volunteer on their fire departments to just for the betterment of their community. There's privatized 911 where towns that maybe they can't afford, they're a little more urban than what a volunteer department could manage. So, but they're still expensive. Having full-time rescuers on your payroll can be expensive. So there are companies out there that contract EMS personnel, whether those are EMTs or paramedics, out to townships. My company does that for a number of communities as well. So EMS is pretty important because we are trying to do, what I like to say is, we're trying to do perfect work in imperfect settings. So I like to any future anesthesiologists, before I offend anybody. I'm just joking. So anesthesiologists, they get to manage the patient's airway in optimal conditions. It is a clean environment. It is quiet. They can adjust the patient's position and height of the table to whatever makes them cozy. Whereas paramedics, we might be crawling inside of a car that's flipped upside down, and trying to manage the patient's airway while they are upside down, while the fire department cuts the car apart so that we can open it and take the patient out. You know, we're working in less than ideal conditions, trying to, you know, do the job of emergency medicine. So it can be very challenging at times. You know, you've got the environment that the patient is in. You've got, you know, as I'm watching my dog walk around, so I apologize if you hear any noises. His name is Mike. He's very friendly. He won't bite. You've got the patient's environment of their home. You know, you go into hoarder houses sometimes, and there's just a very small path to get you, your partner, and your gear to where the patient's at. You'll find them in far from ergonomic positions where you have to try and lift them to get them, you know, to your equipment so that you can get them out of that environment and begin treatment. So it definitely has, it keeps things interesting. You know, we function, like I said before, in a variety of different settings. So rural settings with your volunteers and having to, you know, manage your patient over a long period of time because the transport time is long, you know, long to the hospital. You know, urban settings where you have, you know, you could throw a stone in any direction and hit a hospital. However, if your patient's having a stroke, that hospital that's right around the corner from you may not be able to handle a stroke patient. So you have to know where your stroke centers are. If you got a patient that's having a heart attack, what hospitals have a cath lab that they can get this patient reperfusing? EMS is in the industrial setting, so factories will, you know, factories and refineries will employ EMS as on-duty, you know, on-site safety personnel for managing injuries before the transport ambulance gets there. There's wildland EMS where people are trained to. You've got your hikers that go out in the woods and they get lost and they become hypothermic, dehydrated, and disoriented. You've got your wildland EMS that are trained for those situations, and we're doing this in the elements. You know, we're operating whether it's, you know, rain, sleet, or snow, and, you know, 911 doesn't get to take a snow day. You know, when ambulances can't get down the street because the street's not plowed, we are getting our equipment and we are walking to where the patient is and doing the best we can to get the patient to the ambulance. I've personally had to do that, and it's not fun. You know, so you're on roadways dealing with crashes, traffic whizzing by you because, or, you know, they're causing crashes themselves because they're staring at the work you're doing, and everybody that's like 20 miles back is all pissed off because gapers delay. But you're out there in the open road, and that provide, you know, it's its own danger there too. So I think knowing what pre-hospital providers have to do is going to be very beneficial to you, because when you're in the clinical setting in the hospital, know that, you know, your EMS providers, the pre-hospital providers, are doing everything they can for this patient to get them to you so that you can give them the definitive care that they need. Get them to the surgeon that they need when they're bleeding internally, because we have no way of fixing, there's, you know, internal bleeds in the field. You know, as far as, you know, I told you earlier, I've been seeing a lot of pre-medical track people joining EMT classes, and I think that's very useful. And the reason for that, and you know, our folks on here can attest to this that have done it. It's a fast track to getting patient contact. You know, you spend a lot of your time, you know, in pre-med and in medical school, hitting the books, learning anatomy, working with cadavers. But you don't learn the soft skills of bedside manner. You don't learn the soft skills of being empathetic with your patients who are going, you know, they call you on the worst day of their life. You know, seeing the variety of different conditions that they deal with up close and personal, and you're going to see that maybe it's a little different than what your textbook is going to tell you. You know, I think it's so, you know, most programs are about a semester long, and, you know, for people that have exposure to medicine, the book work isn't usually challenging, but the hands-on stuff can be, because when you think about it, it's one thing to read it out of a book and commit it to memory. It's another thing to take that knowledge and put it to your hands to deliver care to your patient. For future doctors, I think that it's very important so that you can get that access to developing your bedside manner, your talking to patients, so that you can properly assess them, because we have to ask them a whole bunch of questions in order to figure out what the problem is. That's the wonderful thing about being in medicine, is the detective work that we do. Your pre-hospital folks are going to give you information about how this patient was found in their, wherever they were at, so that you can think a little deeper and go, okay, if they were upside down in this car and it was 30 degrees outside and their windows were busted open, and EMS wasn't activated until 30 minutes, after somebody found them, and they've been sitting there in the cold upside down in this car, going to give you a little heads up of this patient's probably going to need some rewarming, and internal injuries that you have to think about. So it gives you definitely a greater perspective, I think, before you start hitting the books hard in your medical programs, that that you get a little flavor of taking care of people. You're going to see people in EMS. You're going to see people that are chronically ill. What I like to refer to as normally abnormal. They are altered mental status as part of their normal. And so when we arrive on scene, because they called us because the person isn't acting right, well, the person normally doesn't act right. So you have to learn how to ask the people around them, their caregivers. How do you go about gleaning that information? So, what's different today? How are they different now than what they normally are? Where's the deviation at? Learning how to take medical speak and converting that to simple words for your patient and patient's family to understand. There's a lot of the human interaction part, I think, is where a big part of the benefit of working in EMS is where it's going to benefit you in the long run as future doctor. You get used to working in less than perfect conditions. So you hone your skills working in less than perfect conditions. When your conditions are ideal, you're going to be extra high speed, in my not so humble opinion. So, you get an opportunity to perfect your assessment skills, your patient interactions. You get to see what the patient's support structure is like, other than when they're standing in front of you at the hospital. You're seeing them in their environment. And, you go into some of these, for example, some nursing homes, and you see that these people are very lonely. A lot of times the best medicine that we provide is really just emotional medicine. There's been patients I've had that have had terminal cancer, for example. One patient that comes to mind, if you'll indulge me in a couple, let's call it a case study of a 35-year-old male who, his life was going incredibly. He just got transferred in his job. He was promoted, so he moved into a very affluent community, and he was outside working in his yard. He's married. He's very much in love with his wife. He has a 1-year-old daughter, and he's outside working in the yard, and he hurts his back. He goes to the hospital, and when they do the imaging, they discover that he's got a very aggressive spinal cancer, and it's metastasized to a variety of different places in his body. And my ambulance was called upon to take him from the hospital to an off-site facility where they did his radiation therapy. And so here's this 35-year-old guy who's at the top of his game, living the dream, and all of a sudden his world is crushed by cancer. He grew a goatee because as he was getting sicker and sicker, he was losing weight because he wasn't able to eat as much. They had to go with putting a feeding tube in his belly so that he could get some nutrition. And he grew a beard just so that his face didn't look so thin, because he didn't want his wife to to see him that way. And so you really get to know these people on a very deep level, and there's nothing I can do. There's no tool in my jump bag. There's no drug in my drug box. There is no protocol that I can follow to make this guy's life better, other than just be there, be human, and treat him like a person and not a patient and not a case study. And that was, that patient was what taught me that. Instead of just transporting him, I'm taking his blood pressure, I'm doing my assessments. There's nothing else I'm doing other than transporting him. So you get to talking to your patient, and I like to use humor in things, because worried people end up sicker faster. Emotional support is very powerful medicine. And on his last treatment, he requested my partner and I, by the way, for his transports, because we made him feel like a person and not a patient. And he specified that when on his last trip. And unfortunately, he did end up dying, succumbing to his illness. But I was better for knowing him. And it was somebody that's you'll treat hundreds of, even thousands of patients, and you'll have a few that stick out in your mind. But it's important to remember that while you are going to treat a whole bunch of people, and you're not going to remember every patient that you treat, they are going to remember you, because you're intervening at a very critical moment in their life. There's you see patients that are very lonely in the nursing homes, or they're, one more case study. An elderly male that we got called to at a nursing facility. And had I not paid attention to my surroundings, if I just walked in the room, saw the patient, did my clinical assessment, put him on the stretcher, and took him to the emergency room, here's what I would have seen. I would have seen a decrepit elderly gentleman laying in his bed, piece of corn hanging off of his mouth, and he is speaking complete gibberish. And they called me for altered mental status. What's different? Nobody knows what's different, but they know he's altered. So, okay, I'm not getting much from staff. This guy wasn't critically sick. You walk in the door and you look and you can tell sick versus not sick. We call it our at the door impression. So as I'm walking in the room, we're always taking in our environment. We call it a scene size up. And I happen to notice that he is surrounded by pictures of who he was before he was taken by age and illness. And you see this guy, he was a World War II veteran. He is dressed to the nines in his uniform, with his stunning wife next to him in one of these pictures. And he's shaking hands with very important people that he had pictures taken with. And outside his room, there was his nameplate. And on his nameplate, the nameplate said GEN before his name. So he was a general. And so I found respect for this guy, paying attention to his environment, going, wow, this isn't just some old guy talking out of his damn mind. This guy was amazing. And you get to see who they were, before they were the patient that was before you. So you really gain an appreciation for that. And it's very humbling. It's incredibly humbling. It's humbling when you have the patient that you do your best for, and no matter what tricks you have in your bag and medications, that sometimes it doesn't work. It's astounding when and very gratifying when it does. And sometimes the only treatment you rendered was holding somebody's hand. But I don't know. That's my little bit on EMS.
Thank you. We can open it up to questions. I know a lot of our members, especially the underclassmen, like freshmen and sophomores, had questions regarding just getting involved with EMS and just getting, just trying to get involved and what they can do to do that. So if you guys have any questions.
Seeing hands go up all over the place on this thing, it's great. Let's see, Mr. Farouk, did I pronounce that correctly? I'm sorry if I don't pronounce your name right.
No, I was just applauding you, but I can ask a question. So I know you said that like training is like about a semester long. How
Mhm.
like intensive and demanding would you say it is?
So most classes will meet if you take it at your college or community college, your local community college, they'll generally meet 2 or 3 days a week, for 4 hours. So some people prefer to take like a 6 o'clock till 10 p.m. class. Um, my service, we have classes that are 12 weeks long, but they're a little more accelerated. So we meet 3 days a week for 8-hour days, so that it's handy for people that are on like summer break, but they want to take a class and get certified. So especially when you're trying to earn up those patient contact hours for your applications. How many hours are they requiring on those anyway?
It's like 50 to apply, but it's recommended to have more than 100 at least.
As much as you can get, really.
Yeah.
Much as you can get.
Is the thing.
Be more than the application in front of you. All right. Well, any other questions?
Yeah, can you actually talk a little bit about the summer program that Superior offers?
Which the EMT program that Superior offers?
Yeah, you said there's one in the summer.
Yeah. So like I said, our programs are 12 weeks. Um, you you sign up. We go 3 8-hour days, Monday, Wednesday, Friday, for 12 weeks. During the 12 weeks, it's a mix of the didactic bookwork mixed in with hands-on skills. We're a firm believer of teaching the hands-on, because most of us tend to be more kinesthetic learners that get into it. And at the end of it, we prepare you to take a national registry exam. So the national registry is a governing body, or a certifying body, I should say, for EMS, and that will lead you to getting your state credentials as a licensed EMT. And once you have that, that allows you to work on an ambulance, get those patient contact hours. Now, our classes are free, but it comes with an attachment, and that attachment is we'd like you to work for 1 year for us as an EMT.
We have a question in the chat. I'm not sure if you can see it or if you want me to read it
Let
off.
me just let me pop the chat up here.
Sure.
Okay, so Shaw. Okay, so planning to take a class for you. Do you care if I read it? If you're on mic.
Yeah, you can read it out loud.
Okay. I was planning to take a class for EMT during the summer at a community college, but it said that I need to take a prior class before that to join the class. So some programs will require you to become an emergency medical responder before taking an EMT class, which I think is a colossal waste of your time. Don't go to a program that requires you to be an EMR before taking EMT class. I mean, it's wonderful for preparing you. If you're somebody who doesn't have basic medical knowledge, I mean, if you don't have a background in biology or anything like that, it may serve you well. But I was an English major before I went into EMT, and I did just fine. I've been in EMS for 24 years now. Professional EMS educator for probably 15 of that. Paramedic. I somehow made it through. Paramedic programs are requiring, and there's some of them, because the enrollment's been so low, I have actually rolled back their prereqs, but they're requiring medical terminology and anatomy and physiology, like a basic anatomy and physiology, prior to entering paramedic school. But honestly, EMS is a field that is we're a dying breed. The enrollments to EMT programs are down. As far as people that want to pursue EMS for the sake of EMS, you'll have the occasional people that are on their pre-med tracks or their medical tracks, and they get in because they want to get that patient contact time and have that advantage. But as far as people staying in the field, EMTs and paramedics are getting harder and harder to come by, and at a time where I'm not sure where the bell curve is of of our aging population, but I certainly don't think we're on the downslope of that. People are living longer. God bless modern medicine, right? But people are living longer, and that need for pre-hospital providers is always going to be there. But it's it can be a very rewarding position, but you're never going to get rich doing it. So it's something that a lot of us do because we just we love the act of helping other people. We're fascinated by the situations that we find. But no, it's back to your question. I'm sorry, I kind of got off on a little tangent there, but no, some people require emergency medical responder. If your community college does that, find a different one, in my personal opinion.
And this adds on to my question. I
Sure.
sent it in the second chat. It's about EMTB. Is that the correct name of the certification that I should be receiving after a program?
So terminology's changed. But emergency medical technician, the B stands for basic. It has changed to now just simply EMT. So the recognized levels, as they're properly pronounced, you've got emergency medical responder, you have, which is EMR, you have EMT for emergency medical technician, you have advanced EMT, which is called AEMT. And for them, their scope of practice expands a little bit. They're allowed to do just a little bit more than what EMTs are able to do. You'll see a lot of advanced EMTs in the rural settings. After advanced EMT is paramedic. They used to be called EMT paramedics, but they just changed it to paramedic. And really, that's the strata of what you're going to see until you get into the private service. And private services hospitals will employ critical care paramedics, which have the even more expanded scope and stuff that they could do. The critical care arena, you're generally going to find you'll find them in ground transport, but you'll also find them in air medical. So you'll find them on the helicopters. You'll find them on fixed wing ambulances, and their job is to keep the patient stable from wherever we're picking them up to wherever we're flying them to, and turn them over to a ground crew, take them to the hospital that they need to get to.
Thank you.
Mm-hmm.
You mentioned that working in EMS, you get to know the patients on a deeper level and you're in these tough situations. So my question is, how do you cope with the mental and emotional stress that comes with this job?
That is an excellent question. The burnout rate for EMS, the last I had seen can be about 5 years. And that's because, like you, when you get into medicine, if you're in emergency medicine, you are going to see your normal people that are being exposed to abnormal situations, and repeated exposure to that really can take a toll mentally and emotionally, especially when you did everything you can, and it can lead to self-doubt. And you have to you not only have to be strong mentally, but you have to have a good support system. A lot of us, when EMS was pretty much strictly fire service, and shortly after that, it was almost taboo to talk about your feelings and to talk about if something kind of spun you sideways a little bit. It was it was considered a sign of weakness to talk about that, and to say that you were affected by something. It's suck it up and plow through. I mean, was really the mentality. That thankfully has that stigma has lessened greatly. So a lot of people will have employee assistance programs where they can get in touch with a mental health professional. The insurance companies will pay for mental health services. There are also peer-led groups, such as we call them critical incident stress debriefings, where everybody that was involved in a particularly bad call, you come together in a room, you shut the doors, and the only person in the room that was not there on the call is the mental health professional that is there to run the meeting. And you say what you got to say, you get everything off your chest, you know, you leave your titles at the door and you say whatever you got to say. The unfortunate thing about CISD is because you're there with everybody that you work around, some people are less likely to open up. So there's another brand of it called critical incident stress management, where it's still peer led, and these are trained people, but they are people that you don't work with. These are strangers that you're talking to. They don't bring a notepad with. They don't jot down your name, so there's no worries about them going and talking to your supervisors. They're just trained to help you get that stuff off your chest, so that you don't internalize it and and burn out. First responder positions. There's a very high suicide rate, unfortunately. It seems like I'm reading all the time about a firefighter or paramedic that took their life just because of the stress of the job. So that is a very, very excellent question, and thank you for asking that.
Thank you.
Let's see, I want to go to the chat here real quick. So let's see, Luke, our Superior's free EMT class is only offered for residents of Indiana, Wisconsin, and Michigan. I cannot find info about Illinois. No, we are definitely firmly based in Illinois. Our main headquarters is in Elmhurst. We do offer the free EMT classes in there. Our website's kind of terrible, so it's sometimes kind of hard to find the. But if you go under EMT classes, you're going to have to navigate careers until you find EMT certification or licensure course, or emergency medical technician basic licensure course. It's going to be titled something similar to that. If I had a link prepared, I would share that up in the chat. Maybe Amir, you could, excuse me, no, where'd you go? If we can get a link up for that, that'd be great.
Is it taking place this summer or no, because of COVID?
We are still having classes despite COVID. So we are doing live training. COVID did force us to go over Zoom classes for a while. We had to get creative as far as scheduling the hands-on training, but no, we are back and functioning in the classroom setting. We are just maintaining social distance. Everybody's masked up. We clean equipment between each person for use. So you can still find live classes. And yes, they will be in the summer. We just run them basically every 12 weeks with a week in between so that the instructor can reset.
Do you know the dates of it this summer? Sorry.
I don't know those off the top of my head. You'd have to look at the website for them to be posted. Yeah, so the website that we can't find, right? Let's see. Nigel, can you take one of Superior's free EMT courses in Michigan? We're living during the pandemic, and then fulfill one-year requirement in Illinois. You could take the class in Michigan and be in Michigan and work, because my company, we are in the Detroit area for Michigan. We are in Northwest Indiana, where we offer EMT classes there as well. We aren't doing those in Wisconsin yet, so the website's a little misleading. Somebody got a little bit overzealous in posting that. We are not cleared to teach in Wisconsin yet, but we are close to Wisconsin. We have a class that's running in Rockford, Illinois. But yeah, we offer in Michigan at the it's called LSTI, the Life Saving Training Institute. Very, very fancy.
I guess this question's a bit more like for your personal experience, but do you have like a set bedside manner, and how much would that change from patient to patient?
Another very good question. So you have to tailor your bedside manner to your patient for sure. It's one of the biggest traps that people fall into. I like to talk about the elderly. I really like to talk about the elderly because they're very misunderstood sometimes. They have forgotten more than you know, and so they tend to get just kind of looked at as frail, sick people. We tend to try. The big trap is when we talk to them, and we talk to them like they're children. They really hate that. When we come up with nicknames to them, and we come up and we're trying to be you know, it's not really at the fault of the provider. They're not trying to be ignorant or anything, but you know, when you walk up to somebody who, you know, is way older than you, and you're calling them like honey or sweetie or something like that, you're trying to be endearing, and it's really insulting. So when you're dealing with the elderly patients, I try and stay old school with them, you know, and I call them Mr. or Mrs. or Ms. And then if they try and tell me like, oh, don't call me that, call me by my first name, or you know, you'll have that occasional patient that says, just call me sweetie, that's fine. Actually, I have a hard time with those. I try not to call them that. So you have those patients. You have you know, patients where you know, maybe they're very their level of consciousness is incredibly impaired, and your bedside manner sometimes is tailored more towards the family and their you know, the people surrounding them, as you do pay attention to the patient. You know, you have behavioral patients, and behavioral patients pose a very unique challenge because especially for the care providers, because you know, it's easy to sit here and tell you to be empathetic and, you know, putting yourself in somebody else's shoes, and it's very easy to have empathy for the sick and the injured. Like, it's very easy to have empathy for them. Empathy comes much harder when the person's illness manifests as behavior and they're uncooperative and they don't want you there, and you know, and truly you can appreciate, like, they're in a kind of a shitty situation. You know, they don't want to they don't want to be committed to a mental health facility. They don't want to be a slave to their medicines. That's chronic. That's usually why they have issues. They take their medicines, they feel better, and then they're like, oh, I feel great, I don't need these medicines anymore. And then once the therapeutic level wears off, they have another episode, and then EMS and police get involved. So your bedside manner does absolutely vary from case to case. And with the behavioral patients, you still you need to be more firm with them because you need to gain cooperation. And the less seasoned providers, they tend to take it as their opportunity to try and be a tough guy. Like, we can do this the easy way or the hard way. And I promise you, you ever say that to a behavioral patient, they're going to take the hard way, because that, you know, so you want to treat them as human, but you also still need to maintain a sense of control while giving the patient a sense that they have some sort of say in the matter, even when sometimes they don't. And you have to do that. That takes skill, because you can't lie to the patient, especially in our behavioral communities. There's a very good possibility that you'll see them again. So if you lie to them now, they'll never trust you again, and you'll never get their cooperation. So it's definitely an art form.
I had a question. I guess, I mean, I know regarding CE, but I was wondering if you could explain to our members regarding the sort of infrastructure that exists for EMTs and paramedics to continue their education to stay up to date with their skills.
So, and take this even when you you know, when you become physicians too, is that keeping up with the science is incredibly important because it changes all the time. You know, even something as simple as CPR, you know, it's changed, you know, from 15 and 2 when I was growing up in medicine to it's, you know, 30 and 2 as far as your compression and breath ratio, and you know, the more advanced classes. So basically, once you get your license, the learning isn't over. You need to maintain it. And you know, states, the National Registry, they will require that you complete a certain amount of continuing education hours throughout the course of your licensure, because your license, once it's conferred upon you, expires in 4 years. So you have 4 years to meet the continuing education requirements. EMTs in Illinois have to meet 60 hours. Paramedics have to meet 100 hours of continuing education. And it has to, it's not like I could just go and take like 100 hours of CPR. They require you to meet a certain number of hours in a variety of criteria. So, you know, whether it's preparatory stuff. So you're talk about things like, have you heard of HIPAA before? Patient privacy rules. All right, so that's stuff that prepares you for going out in the field that's considered preparatory. You're going to be required to have X amount of hours in cardiac, X amount of hours in medical, geriatrics, peds, and OB, because they want to make sure that you're getting a variety in your continuing education.
In terms of the 1 year requirement, if you do your class through Superior, is that full time or part time? And then what's the scheduling on that?
We do prefer full time. That's because if we're gonna be providing a free training, we kind of want our return on investment. So it's kind of hard to speak to that, especially for people that are you're gonna be here for the summer and then you're gonna go off to school. But if you happen to be going to school locally, maybe that's something that you could do is pick up shifts and maintain full-time hours for that year while you're doing your undergrad stuff, and then when you're off to to your medical schools and whatnot, then your requirement's been met. You can always come back and pick up overtime with us. I have a very close colleague of mine who he started off as an EMT. I taught his orientation class when he started at Superior, and it's neat for me to see him sitting in that chair as a starry-eyed brand new EMT. He went on to become a very, very skilled paramedic. He became a critical care paramedic. He was flying on the helicopters, and well, damn, he decided to go off and become a doctor. So he'll be probably in the matter of a month or two be referred to as Dr. Dan, which I've been calling him that for years anyway. But it's kind of neat seeing somebody that started off in EMS and they went on to become a physician, and that's not very uncommon. Some people will come from EMS and they'll take different tracks. They'll go to become physician assistants. They'll go to become physicians. They'll go to become nurses. So EMS is kind of can be a jump off point of medicine for a lot of people too.
And then I think Luke, you had brought this up. What are kind of the typical shifts and the typical hours expected out of working as an EMT or an EMS
Sure.
in general?
The shifts can vary, whether you're working 4 10-hour shifts, 3 12-hour shifts. Some of us still work the 24 hours on, 48 hours off, which sounds sweet on the surface, but we're a very, very busy company. So as far as the start times, end times, things like that, it's not your 9 to 5. You might have shifts that start at 10 o'clock in the morning and go until 10 o'clock at night or midnight. It's we staff based on the need. Believe it or not, there is software that trends in our dispatch center. It trends, and using that software, it can predict what areas are going to get busy and when. It can predict what times are going to get busy and when. So we tend to staff around those needs, because while it's great sitting in the ambulance waiting for a call, EMS used to stand for earn money sleeping. It's it gets very expensive running that as a business model. So they try and schedule it around the call volumes. See, I see an interesting question here, Nigel. You said related to the 1-year commitment, do you choose the specific area, such as underserved populations? We tend to be no matter what station you're out of, we're not really geographically limited. That's what's interesting. Your station, a day at Superior, your station is where you park your car in the morning, and then you're off to wherever the winds take you, because we're not jurisdictionally bound. So we don't have a certain response range. The call has to start in Illinois. That's about the response range that we have. I've taken people from Maywood, Illinois, and I've taken them all the way out to South Bend, Indiana. So your day is that's kind of the neat part about the job, is it's you're kind of off to the winds. You see areas that you haven't been to before. And a lot of times we do end up in those underserved communities.
I guess kind of stemming from that, how much would you have to like work with other facilities? Because you don't have jurisdiction, right? You're gonna be like all over the place.
So are you talking about like interagency cooperation? So like how well do we work with the fire department and things like that?
Or just, other EMS facilities like across the landscape, I guess.
So there's Superior is obviously not the only game in town, and I hope I'm answering your question when I say this, but I like to think of it as no matter who's signing your paycheck, we all do the same job. As far as cooperation goes, I think a good example of cooperation, interagency, whether you're competing or not, it all comes together in times of national disaster. So my organization is part of a call list that is, so say for example, a hurricane hits and they need extra EMS help because they're gonna send EMS to that region to evacuate people that are in the danger area, like hospitals and nursing facilities, people that can't move themselves. It's going to take more than just their fire department and their local privates to accomplish that task. So a very large private company known as AMR, FEMA makes a call to AMR. AMR starts reaching out to all of the ambulance services on their resource list. Hi, Superior. This is AMR. We've got a call out to Louisiana for an incoming hurricane. What can you commit to that? What can you commit to the effort? And we'll tell them. And then we don't move until they call us back and say, yes, we need you. And we're going to be there lined up with our competitors, all for a common cause. Did that answer your question, or?
Yeah, it did.
Okay.
Thank you.
We try and play nice in the sandbox with everybody. We all do this job. I've worked, many a shift where I'm dropping somebody off at a nursing home who's not very sick because they're done being sick. That's why I'm taking them back. And another ambulance crew from a competing agency is there with somebody who is really, really sick. And my partner and I jumped in to help them out because it's not about, it's not about who's on your chest at that point. It's about the patient and, helping a couple of, fellow first responders take good care of somebody.
Well, as we have one more minute left in our meeting time, if we have any last minute quick questions, we can kind of let that slip to Brian. Otherwise, thank you so much again, Brian, for stopping by and sharing your personal experiences with EMS and just providing more information to our pre-med organization on EMS and how it can better us for our career path in the future as well.
Absolutely. It was my pleasure. And thank you guys for the very thoughtful questions and the time and attention.
Yes, everyone, let's one more virtual round of applause. I'm going to be pulling up here the PowerPoint again, but I definitely want to emphasize again everything Brian was talking about. This is really those soft skills, those interactions. I like to think that the job sort of makes you a storyteller. You could ask me any number of things about like, oh, what about that one patient you had, or this guy, and I could go on and on about the sort of realizations that come with it. Definitely consider it, especially for our freshmen and sophomores. I initially didn't think I had it in me, but then you kind of let yourself try things. Don't let yourself be limited by what you think you can't, or that like, oh, it's going to be too challenging for me. Definitely let yourself experience it if you have the opportunity. And Brian, I don't know if you have time afterwards. If someone else still has questions, you can feel free to stay on by with us and ask those questions. But just to conclude here, okay, here we go. Next week's speakers again. We have Whitney. I'm calling her Whitney because I actually have the opportunity to know her personally, from Stritch School of Medicine, coming in on the 16th, going to be very important again for our members that we're able to come out for OUWB, talking about admissions, a very, very interesting look at what it takes and what it takes to get into med school, what med schools look for. Always a good outlook and perspective into that. And once again, Dr. Witkotsky, he's a really, really cool guy. I'm just going to emphasize that again. Definitely not a meeting you want to be missing. But again, not next week, the week after that, this will be the meetings that we have. And here's our traditional final meeting. Thank you again to everyone for coming out. And again, happy spring break and best of luck to all midterm takers that still have some for the rest of the days. Stop recording now. Okay.
All right, bye. Thank you.